and today I'll be talking about um, really baroregulation of blood pressure and how arterial baroreceptors, adrenergic receptors, and cholinergic receptors facilitate that. The reference is going to be from Richard Klabunde's website. So all the images that are in here are the publicly available work of Richard Klabunde, PhD. Please use this for educational purposes only, um, because this is not my uh, material. If it was up to me, use this for whatever you want. I don't care, but please use this for educational purposes only because the work is that of Richard Klabunde's. All right. So you have two different baroreceptors. I will say the ones that we care about are the carotid sinus receptors because they're active in the 60 millimeter mercury to the 180 millimeter mercury range, which is where most physiologic blood pressure is going to be. The aortic arc receptors are more important at the extremes of blood pressure. So it's not that they're not important, but when we typically talk about like the carotid baroreflex, we're talking about the carotid, right? There is a baroreflex for the aortic arch receptors, but they don't operate within the usual blood pressure regulation ranges. So you have innervation of the right and left internal carotid. So you have your carotid sinus. Why is it called the carotid sinus? Because it opens up a bit. And this is going to be innervated by the glossopharyngeal nerve. So cranial nerve 9, the glossopharyngeal nerve. And that's going to synapse onto the nucleus tractus solitarius. I'll draw that in real quick. That's going to synapse on the nucleus tractus solitarius, and that's in the brainstem. That's in the medulla. All right? It's in the brainstem medulla. All right? And the aortic arc receptors are innervated by the vagus nerve, and then that synapses onto the nucleus tractus. So nucleus tractus solitarius. Now, there's one of two things is going to happen. So let's say you have decreased baroreceptor, so firing. What is decreased baroreceptor firing? What does that mean? So the baroreceptors, they detect stretch. They don't detect pressure, they detect stretch, with the corollary being if there's more pressure, there's more stretch. So let's say the carotid sinus is not being stretched. So you're going to have decreased firing of baroreceptors. So you have low blood pressure, not enough blood is going through the carotid sinus. And if you think about it, this is a very strategic place to have blood pressure regulation because there's a very important organ or region of the body that the carotids are going to supply, and that's going to be the head and the brain. That's very important. So it makes sense that we'd have carotid sinus baroreceptors because they're going to monitor the blood pressure by monitoring the amount of stretch. That's the way they can uh, start that signaling pathway if there's a risk of decreased perfusion to the brain. Now, if there's decreased firing, what's going to happen is we're going to have increased sympathetic activity, and we're going to go through the mechanisms of how and why. But at the end of the day, when there's decreased arterial pressure, you have decreased baroreceptor firing because there's less stretch, and you're going to have increased sympathetic activity, and that's going to hit the gas pedal on both constricting the blood vessels and increasing cardiac output. Because when you mean arterial pressure, when you put the equation together, it's dependent on two things: the systemic vascular resistance and the cardiac output. So sympathetic drive increases both of these to increase the mean arterial pressure. And then once the pressure goes up, the baroreceptors aren't going to fire as much, and you've completed your feedback loop. At the same time, you'll have decreased vagal activity, and that's important because if the sympathetic nervous system was the gas pedal, vagal activity is the brake. All right, so you take your foot off the brake, decrease vagal activity, take your foot off the brake so that cardiac output can come up. Vagal activity, and this is a common misconception, the parasympathetic nervous system doesn't really communicate with blood vessels. it's mainly the sympathetic nervous system that innervates blood vessels. There are some blood vessels that are innervated by parasympathetics, but that's not the rule. Those are more the exceptions to the rule. All right, so when we think about the vagal influence on our blood pressure, you want to think of it in terms of the cardiac output itself. All right, because increased vagal activity is going to increase the cardiac output. Increased vagal activity is going to be a brake and decreased cardiac output. So now that we've generally mapped this out, let's move on to the next topic. Here you can see that this is the normal sensitivity. Let me switch to my laser pointer. This is the normal sensitivity. All right, but what happens in states like chronic hypertension or transiently during exercise, but more chronically, like in hypertension, is that the set point shifts to the right. All right, so the set point shifts to the right. All right, and this is one of the things that are being investigated as a way to treat idiopathic essential hypertension. In other words, hypertension that isn't coming from any other cause, any other medical condition. The person just has hypertension. There's some theories that the cause of that is a shift in the set point. And there's some experimentation seeing how to stimulate the carotid receptors in a way or destimulate them in a way that resets, brings the set point back down to here. Now, I do want to point something out, that if the change in pressure is occurring over a long period of time, that the receptors get used to it. Okay, so if they're used to this much stretch and all of a sudden they're getting this much, there'll be a firing. There will be a firing response, right? However, if it's at this level for a really long amount of time, they'll just get used to it. Okay, so to summarize the baroreceptor reflex, what's going to happen is that, let's say you go from you're lying down and then you're standing up. All of a sudden, not enough blood is getting to the head, so the carotid sinus will not be detecting stretch. Okay, and that's going to send a signal through the glossopharyngeal nerve to the nucleus tractus solitarius of the medulla, and it's going to say, hey, not enough blood, we got to speed things up. It's going to hit the cardioacceleratory area. You don't have to have that memorized, but it's called the cardioacceleratory area, and it's going to inhibit the cardioinhibitory area. All right, that way the heart gets the signal of, yo, not only do I need to pump harder, I need to pump faster. That increases the cardiac output. At the same time, the rest of the vasculature is being more vasoconstricted, and that way that also contributes to increasing the mean arterial pressure so that you can achieve a perfusion pressure that the brain needs. All right, that is the carotid reflex. Long term, and that's a very short term reflex. However, the long-term reflex is the renin-angiotensin-aldosterone system, and I already have a video on that you can watch if you're interested. But that's the hormonal mechanism, long-term hormonal mechanism of pressure control. And importantly, one of the activators of that is increased sympathetic drive. So when in states of very low blood pressure and the carotid sinus does not detect enough stretch, not only is it going to cause that short-term reflex, that sympathetic drive is going to activate the renin-angiotensin-aldosterone system. So there's some communication between this short-term response and this long-term hormonal response. So the sympathetic nerves are going to innervate the sinoatrial node and the AV node, and that's going to be adrenergic. There's also going to be parasympathetic innervation of these nodes. Now, focusing more on the sympathetic nerves, the adrenergic nerves are going to release norepinephrine. All right, the neurotransmitter is norepinephrine, and that's going to bind to beta 2 and beta 1 receptors. It's going to increase how fast the heart's contracting, how strongly it's contracting. It's going to decrease the amount of time in between contractions, etc. So just think big picture. Again, sympathetic nervous system is the gas pedal. Okay? Now, the most important adrenoreceptor with regards to the heart is the beta 1. So the beta 1 receptor is the most important one with regards to the heart. All right? Keep that in the back of your head. Norepinephrine can also bind to alpha adrenoreceptors, and that can cause some increases in inotropy, and that's not shown in the figure. But something I want to point out is that there's also epinephrine. And epinephrine also binds beta, but at very high doses, it'll bind alpha as well. And we'll talk more about that later. And we already have in the previous video, we did discuss that a bit, but we'll sort of circle back to it. So sertraline catecholamines are another source of norepinephrine epinephrine. Remember, norepinephrine isn't there's no epinephrine usually coming from the sympathetic nerves. It's norepinephrine that is the neurotransmitter, and there's epinephrine coming from the adrenal glands, but there's also norepinephrine coming from the chromaffin cells of the adrenals. And so that sort of covers this arm of the figure. Now let's go over to the parasympathetic. So the parasympathetic nervous system also innervates the nodes. And that's actually extremely important because while, again, the sympathetic nervous system, it innervates a lot of stuff. It innervates, it can affect the contractility of the heart. It's going to change the rate. There's a lot of stuff it's going to do. It's going to constrict blood vessels. The parasympathetic vagal nerves are mainly going to act as rate control. All right, they're going to act as rate control. So they will mainly be acting on the sinoatrial and AV node. Okay, so that's when we need to calm down, when we need to relax. Why do we say take very deep breaths? Because deep breaths, those activate the parasympathetic nervous system, and they activate the vagal branch of this, balance. And because the vagal nerve is now more active, it calms the heart and it sort of counteracts that anxious effect. All right. Additionally, let's say you had too much parasympathetic stimulation. That can cause arrhythmias. It can cause blockages in conduction, and it can also cause bradycardia or slow heartbeat. Brady means slow, tachy means fast. All right. So let's say someone had tachycardia. We will try to have them do a vagal maneuver, something that's going to increase vagal stimulation. That can be a carotid, forgetting its name, the carotid massage, which gives a strong. Remember, what does the carotid sinus detect? Stretch. So it's a carotid massage. Please don't do it to yourself. Especially don't do it with both hands or you'll pass out. So you do a carotid massage, and what that tells the carotid sinus, oh my God, there's so much pressure. Because there's so much pressure, we need to switch on vagal stimulation to calm things down. Okay, because remember, stretch causes the if something was low, we were getting the acceleratory response from the sympathetic nervous system. However, if the stretch is too high, we're going to get the cardio-inhibitory response from the medulla. So let's say someone has a tachycardia. That's because of the AV. So it's supraventricular. It's not the ventricles that are causing this rapid heartbeat, but it's just something is being conducted and it's forcing the ventricles to contract. What we can do, because it's a tachycardia, we can stimulate the carotid sinus ourselves using a carotid massage. And what that will do is that it'll signal vagal stimulation, and that vagal brake effect will slow things down because it's such a potent effect that it has on the SA and AV node. All right. Another thing that works is the Valsalva maneuver. That's also a vagal maneuver. All right. And then we can also try to use other pharmacological interventions, but usually you can start with that non-invasive method first. One of the risks of doing the carotid massage, though, is if you don't, that's why you always auscultate. You always auscultate before you palpate, because if someone has a carotid bruit from an atheroma or buildup of plaque in the artery, and you give it a nice little rub, you dislodge it, goes through their brain, congratulations, you just caused a stroke. So we always auscultate before we palpate. Word to the wise. And here we're just looking at some of the more micro physiological details of sympathetic signaling. You can be tested on this on the USMLE. I would say looking at the big picture, because I always like to think of things in terms of the big picture, the norepinephrine is going to activate beta receptors and epinephrine as well. And the epinephrine is going to be coming from circulating catecholamines, so from the adrenal chromaffin cells. The reason why I'm emphasizing this is because if you have a tumor of the chromaffin cells, which is going to be called a pheochromocytoma, you will have a lot of upregulation of this. All right, so when people have these random spikes in blood pressure out of nowhere, their heart starts pounding out of their chest and they're sweating like crazy, all this sympathetic drive out of nowhere, pheochromocytoma is going to be on the differential, right? It's either an anxiety attack or a pheochromocytoma when stuff like that happens. When the blood pressure spikes really hard, you're erring more on the side of a pheo, but they're very rare. Typically, somebody who suddenly has their heart beating and suddenly has palpitations, common things are common, it'll be anxiety. But the underlying physiology is somewhat the same. It's enhanced sympathetic drive or hyperthyroidism because the thyroid hormone uh, facilitates more beta-adrenergic. So that's sort of something that's not drawn here that I want to bring up. That thyroid hormone makes everything you see here more enhanced. It doesn't cause any of it, but it enhances it. So hyperthyroidism, you're going to have issues with the heart like palpitations, fast heartbeat. Why? Because the sympathetic nervous system is a gas pedal, and thyroid hormone makes you burn that gas more efficiently unless you hit higher speeds. All right? If it's a pheo, because it's going to be releasing a lot of sympathetic drive, you get what? Higher heart rate, higher heart contractility, etc. Okay? So keep that in mind. All right, big picture. Why am I emphasizing that circulating catecholamines or circulating norepinephrine or can cause this? Because those can be released by tumors like pheochromocytomas. Why am I emphasizing that the sympathetic nerve releases norepinephrine and that causes this? Because if you have an anxiety attack, you're releasing, that's a lot of sympathetic drive in a panic attack. All right. So now going to the next step, it's GS associated, and this you must know this. This you must know that the beta adrenoreceptors in the heart, the beta adrenoreceptors in the heart are GS coupled, they're G protein coupled receptors, and they're stimulatory. Because they're stimulatory, they're going to increase cyclic AMP by upregulating adenyl cyclase. And if you haven't watched my G protein lecture, I strongly recommend you pause this one and go back to that because I explain this in detail if you don't understand this process. It's important you understand this process, not in this lecture, but for the USMLE. So you have a G stimulatory protein that's going to upregulate adenyl cyclase, and that's going to increase heart rate, contractility, conduction velocity. In other words, the speed at which electric signals can go through the heart. And that is important, all right? The sympathetic drive is GS protein coupled. That's going to increase the activity of adenyl cyclase. That'll increase cyclic AMP. And it's the increase in cyclic AMP that's going to cause all this other stuff. The way cyclic AMP does that, I don't think you need to know for STEP, but I'm just going to share it, is that it activates protein kinase A. And protein kinase A, first of all, in terms of conduction velocity and heart rate, it's going to increase phase 4 in the pacemaker currents. And if you don't know what that is, pretend like I didn't say it and move on with your life. It's also going to phosphorylate areas in the sarcoplasmic reticulum. And remember, when muscles contract, calcium is released from the sarcoplasmic reticulum. So this phosphorylation of those channels is going to enhance the release of calcium. That's going to make it pump much more strongly. All right. So over here, we have something a bit more different. Right now we're looking inside the vessels. So same general idea. What is beta adrenergic signaling coupled to? G stimulatory. What's that going to do? Increase cyclic AMP. But here, note that the cyclic AMP is going to inhibit myosin light chain kinase. So vascular smooth muscle has beta-2 adrenoreceptors. And what are those going to be activated by? Norepinephrine, released by the sympathetic adrenergic nerves, or if there's an ectopic source, like a pheochromocytoma, or just naturally released catecholamines during the fight or flight response. But either of those things, whether it's coming from a sympathetic nerve or it's coming from the chromaffin cells, physiologically or not physiologically from the chromaffin cells, those are going to bind the beta-2 adrenoreceptors. Vascular muscle has beta-2 adrenoreceptors, and they're going to be activated. And when they're activated, they're coupled to this GS protein. All right, they're coupled to this GS protein. And that's going to stimulate the formation of cyclic AMP. And I really want to contrast something for you. Cyclic AMP was a go, 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 go signal in the heart, right? Well, it's a relax signal in the blood vessels. The idea being, if it's telling the heart to contract harder, it wants the blood vessels to transiently dilate. All right. Eventually, there's other things related to norepinephrine that cause an overall vasoconstriction, especially at much higher doses with epinephrine. But for now, I want you to keep in mind that cyclic AMP, unlike in the heart, causes relaxation in um, vascular smooth muscle cells. All right? Why? Because cyclic AMP is inhibiting the myosin light chain kinase. What does myosin light chain kinase do? It phosphorylates the myosin light chain. So if you inhibit that, you don't get phosphorylation of the myosin light chain, and you don't get smooth muscle contraction. So using a beta-2 agonist will cause relaxation. And don't worry too much about what's going on this side. Generally speaking, just understand that calcium is released into the cell, whether it's coming in through the L-type channels or coming out of the sarcoplasmic reticulum. It has to associate with calmodulin. Calmodulin is a domain that interacts with a lot of, it's relevant to a lot of proteins. And just think of this as calcium has to bind to calmodulin to get to where it wants to go. And the GI tract, it'll bind to calbindin, which will bring it into the rest of the bloodstream. But right now, what I want you to focus on this slide, don't concern yourself with this. Concern yourself with this part here. You have a beta-2 adrenoreceptor that's stimulated, GS, cyclic AMP increases, but unlike in the heart, in which cyclic AMP phosphorylates protein kinase A, and then protein kinase, not phosphorylates protein kinase A, activates protein kinase A, and then protein kinase A phosphorylates a bunch of targets, and that causes increased heart rate and increased contractility. In the smooth muscle, cyclic AMP inhibits myosin light chain kinase and prevents phosphorylation, and that causes relaxation. So given that there's a beta-2 receptor and a beta-1 receptor, and we've seen that while beta-1 in the heart is more associated with contractility and heart rate, that beta-2 in the vasculature was more associated with relaxation of the vasculature, which raises the point that do you want to promote, whether you want to promote relaxation or oppose relaxation, or do you want to promote contractility of the heart or oppose contractility of the heart, you're going to have to make a decision between beta-1 and beta-2 blockade. Or you might want to block it. There are situations where you want to block everything, just complete beta blockade, all right? And you're well within your, and it's going to differ based off the clinical situation. So I'm not going to delve into when you use beta-1 or beta-2. This is just, I'm going to do a broad overview of beta blockade. So beta blockade means we're going to use an antagonist to prevent sympathetic signaling, or adrenergic signaling more correctly, because not all adrenergic signaling is from the sympathetic nervous system. Some of it, like we said, is from circulating norepinephrine and epinephrine released by the adrenal chromaffin cells. So in terms of the heart, you're going to have, if you're blocking sympathetic, you want to think just the opposite of what normally happens. So you'll get decreased contractility, you'll get decreased relaxation, you'll get decreased heart rate, you'll get decreased conduction velocity. And familiarize yourself with these terms. Inotropy means contractility. Lusitropy means relaxation rate. Chronotropy means heart rate. Dromotropy means conduction velocity. And beta blockade decreases all of these. Why? Because normally sympathetic drive or adrenergic signaling, again more accurately, will increase these. In terms of the vasculature, normally you're going to have, that's right, dilation, because it's beta-1 GS signaling causes contraction in the heart, but beta-2 GS signaling causes relaxation. So what's going to happen from a beta blocker? You're going to get smooth muscle contraction. All right, so beta blockade will cause smooth muscle contraction. All right, you'll have a very mild vasoconstriction. Therapeutically, we're going to use this for hypertension, angina, myocardial infarction, arrhythmias, and heart failure. So if the heart's beating too fast, we can use a beta blocker, right? And there's a lot of different arrhythmias, so I'm not going to get into this. And there's a lot of different treatment, and there's a lot of different classes of antiarrhythmics. So we're not going to get into this. I'm just going to tell you that beta blockers are a type of antiarrhythmic, depending on the indication. In heart failure, we're going to use beta blockade. In MI, we're going to use beta blockade unless otherwise contraindicated. In angina, we're going to treat that with beta blockade. Why? Because by really decreasing the drive on the heart, we're decreasing the load on the heart. And you can see why that would be important if someone is in decompensated heart failure or acute heart failure or myocardial infarction, they have a heart attack, or angina. The supply outweighs is not enough for the demand of the heart. Even in hypertension. So overall, there's going to be a decreased blood pressure. Even though there's a mild vasoconstriction, when you use a beta blocker, keep in mind there's so much other stuff that's going down that you will bring the mean arterial pressure down, because mean arterial pressure is a product of systemic vascular resistance and cardiac output. So even if this goes up a little bit because of the smooth muscle contraction, this is really going to drop anyway. This is really going to drop. All right, because you're decreasing contractility, you're decreasing, all these things together are going to affect the heart rate. All right, all these things are going to affect how rapidly the heart's going to beat. So you're really just decreasing how much cardiac output you have from this side. So I'm going to write next to here, this is the cardiac output decreasing, and this represents the systemic vascular resistance increasing just a little bit, and this outweighs it more. And that's why we can use it to treat hypertension, because I know sometimes second-year medical students, they see, what? Why would I beta block and increase vasoconstriction? Isn't that going to increase blood pressure? If it happened alone, yeah, but beta 1 signaling is a thing. All right. That being said, you might choose a beta 1 specific blocker if you don't want to get this beta 2 driven effect. So again, that's why I'm not going too much into beta 1 and beta 2 here, because there'll be so many hairs to split. I'm just trying to give you a general idea of what the clinical picture is. All right, question time. In which of the following cases would you think that beta blockers are contraindicated or at least warrant caution, and why? All right, so I'm going to pause, and you might not know the answer to all of these, but I want you to think about each one. So I'm going to pause, or you should pause, and take the time to answer. All right, hopefully you listened and took a chance to go through these. The reason why in all my videos I say pause and take a moment to answer is because in adult learning theory, the process of committing to an answer makes you remember it better, whether you got it right or whether you got it wrong. That act of committing and then being like, ah, or dang, or yes, that helps you remember things. So that's why I ask you to pause and try to answer on your own before I provide the answer. Because if you're sort of hedging your bets in your head and you're like, and you hear me say the answer, like, oh yeah, I knew that. It's not the same as saying, this is what I think it is, and then waiting for the confirmation or denial. All right, so sinus bradycardia, are you going to beta block? Absolutely not. Because the heart's already beating slower, you beta block, they're going to die. Why is this important? Because typically, someone's presenting with a heart attack, that's not good. You want to decrease the load on their heart. You might think a beta blocker is a good idea. Usually it can be a good idea. But if you were to give that beta blocker while the person has a heart rate of 40, bad things are going to happen, right? You're playing with fire, because beta block is going to decrease relaxation time. It's going to decrease conduction velocity. It's going to decrease heart rate. All right. If someone has AV block, so don't worry too much about this one. If you're watching this video and you're already familiar with what this is, then I'll answer on your behalf. But if you're like, what the heck is AV block? Don't worry too much about this. But you would not use it in partial AV block because you don't want to depress conduction further. Remember, beta blockers decrease conduction velocity, and AV block is a condition with decreased conduction velocity. Asthma and COPD, remember what we said about smooth muscle contraction? All right, well, there's beta-2 receptors on the smooth muscle of the bronchus. So if someone has asthma or COPD, which already is not good in terms of airflow, because some of you might not have studied pulmonology yet, so I'm not going to make assumptions and use big words. But I'm going to generally tell you that asthma and COPD, it's obstructive. There's an obstruction to airflow. And let's say this is the bronchus in black, and this is the smooth muscle around it in red. And this smooth muscle has beta-2 receptors, and you block those receptors, what are you going to get? Constriction. And what do you think is going to happen? Let's say somebody already has obstructive disease, so I'm going to use yellow to highlight this idea. Although this is not what obstructive disease is. I'm just going to use yellow to indicate more resistance than an average person would have in this airflow. If you were to constrict, you're going to make that so much worse. All right? So diabetes, you would have to be careful because remember, you might not know this yet actually, but when you have low blood sugar, one of the things that activates is the sympathetic nervous system. And it's like a jitteriness, sweating. It's like, it feels like a sense of anxiety. That's the normal response to hypoglycemia, low blood sugar. In a patient with diabetes, if you put them on a beta blocker, they're not going to get that warning signal of that jitteriness, the tiredness, the anxiety. They're not going to feel it. So their blood sugar can get really low without them even realizing it until they pass out or it's not enough for the brain. All right, so you have to be careful. It's not a contraindication, but if you're beta blocking someone with diabetes, you're going to have to counsel them on very tight glycemic control and making sure that they're, not messing around with how much sugar they're bringing into their body. Because if they're not having enough sugar and they end up hypoglycemic, then like they're not eating enough and they're taking too much of their meds, and now they're, it's just a bad situation. So you want to be careful about co-administering these with calcium channel blockers. I think this is a given. Calcium is involved in contraction. If you're blocking calcium and then you're throwing a beta blocker on top of that, you got to be careful. Hypertension associated with emotional drive. This is the only thing on here that is not contraindicated. In fact, if there's emotional drive, like a lot of emotional stress is causing this sympathetic response and this hypertension as a result of it, beta blockers can actually be very effective because they directly target those beta receptors. So if the blood pressure is because of increased beta adrenal receptor signaling, because of a lot of emotional stress, beta blockers can actually treat that pretty effectively. So basically, all of these are either contraindicated or you need to slow down. And this is the only one where it's like, yeah, this is a very good reason. All right, so talking about atropine, I'm going to speak very broadly. So we're in the heart right now, okay? And where are we specifically? The SA and AV nodes, because like I told you, the vagal nerve, its greatest influence is going to be on the SA and AV nodes. It's going to release acetylcholine, and normally, ignore this X here, normally acetylcholine will bind to the M2 receptor, and that's G inhibitory, okay? The beta 1 receptor in the heart was G stimulatory. So what's going to happen is a G inhibitory is going to do the opposite of everything the G stimulatory did. If that GS in the heart was increasing cyclic AMP and increasing protein kinase A, and increasing conduction velocity through the heart with regards to the nodes, what's going to happen with parasympathetic signaling, with the vagal signaling, is that acetylcholine is going to stimulate the inhibitory G protein, which is going to decrease the activity of adenyl cyclase, and that's going to decrease cyclic AMP, and it's going to decrease conduction velocity. So everything goes in the opposite direction. All right? So let's say somebody has a very slow heart rate, and we think it's because there's too much vagal influence. We can put IV atropine, and we can see if the heart rate is going to come back up. All right, so we can push atropine. If the heart rate comes back up, it's a sign that, okay, some of the issue might be from the vagal nerve. So the signs of atropine toxicity, remember, if atropine is blocking cholinergic signaling, then atropine toxicity is going to be anticholinergic in its presentation. So the anticholinergic symptoms are going to be tachycardia, dilated pupils, dry mouth, urinary retention, inhibition of sweating, which is called anhidrosis, blurred vision, and constipation. So it's going to be tachycardia, it's going to be pupil dilation, it's going to be dry mouth, urinary retention. I'm just going to write no P because you're going to have urinary retention, blurred vision, no pee and no poop because you also get constipation, blurred vision, and no sweating. All right, those are anticholinergic, and you do need to know this. This basket, the anticholinergic symptoms, you do need to know this. All right. So bringing it all back to the vasculature, I want to talk a bit about the alpha signaling. Okay. So how does norepinephrine cause contraction? Well, norepinephrine, so we said that there's a transient vasodilation as a result of norepinephrine, right? So this might be confusing. You might be like, wait, but I thought that beta 2 vasodilates. Well, the thing is, norepinephrine preferentially binds the alpha receptors. And the alpha receptors cause vasoconstriction. So that's why you might have a transient vasodilation when there's norepinephrine increases, but that's going to be overruled by the alpha signaling. And all I want you to really worry about right now with regards to the alpha signaling is that it's going to cause smooth muscle contraction, and the process that opposes it is M3 signaling that's going to increase nitrate, and that causes relaxation. That's all that I want you to know right now. Okay? Now, while epinephrine has a very high affinity for beta 2, all right, so we talked about norepinephrine and beta 2, so now I want to talk about epinephrine and beta 2. Epinephrine, at very high doses, at high concentrations, it'll bind the alpha 1 and alpha 2. All right, so epinephrine at low doses binds to beta 2 and causes vasodilation, but at high concentrations, it will bind the alpha and alpha 2. That'll override the vasodilation that comes from beta 2 and cause vasoconstriction. So low amounts of epinephrine will cause vasodilation and contractility in the heart. However, high amounts of epinephrine will still cause contractility in the heart, but it'll also cause vasoconstriction instead of vasodilation. Okay? So again, at low doses, epinephrine causes vasodilation in the vessels and higher contractility and heart rate and all that stuff in the heart. At higher doses, not lower doses, at higher doses, it will also bind alpha 1 and alpha 2, and that'll override the vasodilation and cause a smooth muscle contraction. And our last clinical correlate is orthostatic hypotension. The reason that being, let's say somebody is sitting down. And this is what orthostatic hypotension is. When you go from supine to standing, okay, so let's say this is Timmy. Timmy was sleeping. Timmy heard his alarm go off because he was late for PBL. He jumps out of bed, or PBL is problem-based learning, or late for lecture, whatever you want to call it. And he jumps out of bed because he's scared. And what happens? Timmy falls. So Timmy was in bed, he stood up too fast, and then he fell. Timmy might have had orthostatic hypotension. And orthostatic hypotension is a decrease in blood pressure, usually by 20 millimeters systolic or 10 millimeters diastolic, that occurs when going from the supine to standing position. All right? And normally what happens when you go from supine to standing is you get your baroreflex, right? You go from lying down to standing up, and then your carotid reflex goes off, and that's going to cause some pathetic drive, and then that's going to increase heart rate and heart contractility and cause some blood vessel constriction and get your blood pressure back to where it needs to be for the brain. In orthostatic hypotension, something is blocking that process. So it could be because of there's just not enough blood in the person. So if the person is volume depleted, so they have low blood volume to begin with, it's like squeezing toothpaste when there's no toothpaste left in the thing. You know what I mean? The other reason could be autonomic dysfunction. So something is deeply wrong with the autonomic nervous system, and that happens in like Parkinson's disease. It can happen with diabetes. You can get autonomic nerve damage in diabetes, etc. There's a long list of causes, so I encourage you to read into that. But what I'm trying to point out here is if there's a problem either with the autonomic nervous system or if the person's volume depleted, you're going to get orthostatic hypotension because either the blood pressure control mechanism isn't working or there's just not enough blood volume for that mechanism to even be useful. All right? And I already talked about this earlier, so I'm just going to repeat it quickly. If somebody has a supraventricular tachycardia and you want to increase vagal tone, you can have them do a Valsalva maneuver. So you put your hand on their stomach, you push into their abdomen, and you say, push your gut, your abs against my hand, right? Or you can tell them to bear down, but sometimes patients don't know what bear down means. All right, and that's it for this lecture.